last presentation. That's Dr. Ahmed Manjra, who specialist pediatrician and an allergologist. So he's got a diploma in allergology and a master's in clinical pharmacology. So he's in private practice, and he's one who's managed to do one of the unique things of being an academic in private practice. So Ahmed is going to talk to us about biologics in autoimmune conditions.
نحمده ونصلي على رسوله الكريم أما بعد فقد قال الله تعالى في القرآن الكريم أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم وإذا مرضت فهو يشفي. In this verse of the Quran, Allah subhanahu wa ta'ala tells us that for every disease there is a cure. I had a hadith here as well, but it doesn't seem to be appearing, but it was similar hadith that was put up before, where قال رسول الله صلى الله عليه وسلم, the Prophet ﷺ said that for every disease is a cure as well. It's as follows. I forget it now. But anyway, it was on the previous slide. I don't know why it's not appearing. But it's a very similar type of thing. And what this verse and hadith tells us is that Allah subhanahu wa ta'ala has created disease, but for every disease there's a cure, and it is up to us as doctors, as human beings, to look for these cures, to better health for humanity. My topic is on biologicals in autoimmune diseases. I'm not an expert on autoimmune diseases. Most of my experience has been with biologicals in problems with allergology, atopic dermatitis, chronic spontaneous urticaria, and asthma. I've been involved extensively in clinical trials with many of these diseases. But there's a very close intersection between allergology and autoimmunity, which is probably why I was given this topic. So I'm not an expert in autoimmune diseases, and I'll try to do my best to try and give you a basic understanding of how biologicals work. So basic immunology, we know there are two types of immune systems. They work together, they work in a very close way, they don't work separately. You get the innate immune system, where your physical barriers fight off infections, viral infections, bacterial infections, parasitic infections, your chemical barriers, and then of course your innate responses, your inflammatory cells that are responsible, such as mast cells, which also have a very important role to play in allergy and asthma, your neutrophils, your macrophages, and your natural killer cells. And then you've got the adaptive immune system, and basically that's divided in two types of immune responses, your cell-mediated immune responses and your humoral immune responses. And most of you are familiar from medical school, your Jell and Coombs, classification of immune responses, and there are 4 different types. We don't have time to go into each one of them. But basically your cell-mediated is your T-cell-mediated responses, and your humoral responses are your B-cell-mediated responses. And you get the production of various types of antibodies, such as IgG, M, E, and D. And each one has a different function. So just very briefly, your adaptive immune system, and you get an innate immune system. Your adaptive immune system, you get T-cell mediated and B-cell mediated. And our focus today is primarily going to be on some aspects of T-cell mediated immunity as well as B-cell mediated immunity. So if you look at just the T-cell mediated immunity, there are 3 types of T-cell mediated immune responses. There's type 1, there's type 2, and there's type 3. As allergologists, pulmonologists, we are mainly concerned with type 2 immune responses. We call them type Th2 high responses and Th2 low responses. And these are the different phenotypes of asthmatics and atopic patients that we see. It also applies to allergic rhinitis as well as atopic dermatitis. And then you get the type 1 immune response, and all of these are involved in fighting infections, and also the type 3 immune response. Now, if you get this regulation of your type 1 immune response, you mainly get diseases like psoriasis, psoriatic arthritis, and rheumatoid arthritis. And as I've mentioned, if you get this regulation of type 2 immune response is skewing towards Th2 hypersensitivity, you get diseases like asthma, atopic dermatitis, food allergy, and so on. And if you get dysregulation of your type 3 immune responses, you get diseases like psoriasis and rheumatoid arthritis and psoriatic arthritis as well. So if you get dysregulation of type 1 and 3, many of these are autoimmune diseases, which I'll speak about a little later in my talk. So your activated antigen-presenting cell stimulates your T lymphocytes to produce different T cell subsets. You can get a Th1 response, whose signature cytokine is mainly gamma interferon, and this is very important because biologicals are made to work against many of these cytokines, and your affected cells are your macrophages, and these are responsible for your cellular responses, your clearance of intracellular pathogens. Then you get Th2, which I've mentioned, and the major cytokine involved here is IL-5 and IL-13, and we know that blocking IL-5 and IL-13 works very well for treating atopic dermatitis and severe asthma. And you also get Th17, Th22, and TREG responses, and each one of these have different signature cytokines, and when they become dysregulated, you get different types of disease causation. So that's very briefly an overview of the immune response and how the immune response responds to different pathogens. As I've mentioned, that the type 1, 2, and 3 immune responses, when they are dysregulated, they result in different diseases. So I won't repeat that. So if you get dysregulation of your type 1 response, you get many autoimmune diseases and cancer as well. Type 2 is asthma, and type 3 is autoimmune diseases and psoriasis as well. So how do you, Allah subhanahu wa ta'ala has created this perfect immune system, adaptive immune system as well as an innate immune system. It works perfectly in most people, but sometimes you get autoimmunity. So the opposite of autoimmunity is immunodeficiency, and of course there's a new term for alopecia areata, and lichen planus. And for each of these conditions now we have biologicals which specifically target the antibodies which are responsible for the causation of disease. The diagnosis, I'm sure most of you are familiar with it, you probably know more about it than I do. As pediatricians, we don't see that many autoimmune diseases, but it's based on symptoms and detection of antibodies. Antibodies are made against the cells and the tissues, and these are detected by different laboratory methods. Antibodies against soluble antigens are normally detected by radioimmunoassays, and of course biological and biochemical assays are also used. And that's of course a topic on its own. So the traditional and conventional way of treating patients with autoimmune diseases was targeting the entire immune system. And the analogy that I can use is that if you've got a patient who has just a little cold feeling on the toe, you cover the patient with an entire blanket. And what biologicals do is specifically target the warming of the toes, not the entire body. So most of these drugs that we have been using traditionally for treating autoimmune diseases, like oral corticosteroids, cyclosporin, azathioprine, methotrexate, MMF, and non-steroidal anti-inflammatory drugs, and of course not so much non-steroidal anti-inflammatory drugs, they have a very profound effect on the immune system and they cause significant immunosuppression. And of course, oral steroids we know have significant effect not only on the immune system but also on multi-organ damage to your bones, liver, heart, brain, and so on. And in fact, recently it's been shown that even inhaled steroids that we use in asthma in children can cause demyelination of the white matter. So we need to be very careful when we prescribe these drugs. Some of these have disease-modifying properties and some of these don't have disease-modifying properties. We don't have time to go into the pros and cons of each one. But when patients fail to respond to steroids, cyclosporin, or general immunosuppressants, then they are candidates for using biologicals. So how do immunosuppressants work? They reduce the activation or efficacy of the immune system. It leaves the body very vulnerable to opportunistic infection, and we know patients who have these general immunosuppressants, we've got to monitor them for secondary infections. And of course, some of them are also used for patients that have transplant to prevent rejection of the transplanted organs. So how are biologicals made? So biologicals are genetically engineered medications from a living organism, such as a virus, a gene, or a protein, and it stimulates the body's natural response to infection and disease. It targets cytokines and cell surface molecules. It is, as I've mentioned, typically the second-line drug that's used for the treatment of autoimmune diseases as well as diseases that have an autoimmune basis. The first-line drugs are most of the conventional drugs which I have shown. I'm not going to go into details here, but this is the procedure in biologic production. It's quite a complex production process, and that's why there are very few biosimilars, not as many as we would want to create competition in the market. So that's the production process. I think an important point is, I'm sure many of you see patients in your general practice or in your specialist practice on biological drugs. There's a special nomenclature that's used for these drugs. So how do we designate biological drugs? So biologicals in the context of autoimmunity are typically named with different suffixes. So for an example, if the biological ends with MAB, M-A-B, it means monoclonal antibody. If it ends with CEPT, like C-E-P-T, it means it's a receptor fusion protein, or UMAB, it's a harmonized monoclonal antibody. So, for an example, omalizumab, which is a drug that we use in patients with chronic spontaneous urticaria as well as severe asthma, ends with a MAB. Then you get TINAB. So drugs which end with TINAB are often used in cancer treatment and are chemically sensitized, unlike biologicals which are derived from living sources. So baricitinib is an example of a drug that ends with TINAB. So you get MAB, you get CEPT, you get UMAB, TINAB, and then you also get JAK molecules which has a different suffix. The suffix TINAB is generally associated with small molecule kinase inhibitors and not generally with biologicals. So many of the drugs that end with tinum are synthetically made and are not derived from living organisms. So they're not strictly called biologicals, although technically they work in a biological sense. So how do biologicals work? They have an effect on the immune system. They block and enhance different arms of the immune system. As I've shown you, the immune system is your innate immune system, your adaptive immune system, and each one has different arms. It's very much like the army. We have the navy, you have the cavalry, you have the air force, and so on. So these molecules specifically target certain arms of the immune system. It's indicated, as I mentioned, when conventional treatment fails. And the most important thing is that biologicals, all of them, are disease-modifying drugs. So they actually modify the disease, not just give you symptomatic improvement. And certainly we've seen these in patients with atopic dermatitis and asthma as well, where patients have prolonged remission after treating them with biologicals. So we've learned how it's designated, we've learned how it's made, we've learned how it works. What are the different classes of biologicals? Basically, there are 5 different classes of biologicals. You get the anti-TNF agents, which work against tumor necrosis factor, IL-6 inhibitors, your B-cell depleters, your co-stimulation blockers, and your IL-17 and 23 inhibitors, which are cytokines. So examples of your anti-TNF agents are infliximab, adalimumab. Adalimumab is a common one. It's called Humira. It's used for many different conditions. And your target is the tumor necrosis factor. And you know tumor necrosis factor has a very destructive effect on the bones and tissues in patients with rheumatoid arthritis. And many of these biologicals have multiple indications. Then you get your IL-6 inhibitors, and IL-6 became a very popular cytokine during COVID because many of these patients had a cytokine storm, and we made it IL-6 as a measure of the severity of the disease and also as a response to treatment. And the drug that used here is tocilizumab, which works against your IL-6. And then you get your B-cell depleters, and the one that we use here is rituximab. And what rituximab does is that basically it knocks out your B cells, and it works on your CD20 receptor on the B lymphocyte, and you get B-cell depletion. If you get B-cell depletion, then you don't make the abnormal antibodies which are responsible for disease causation. Then your 4th type of biological is your co-stimulation blockers, and it's abatacept. And again, you can see the suffix shows at which receptor it works. And this works on your CTLA4 receptor, which is also a causation factor in diseases like rheumatoid arthritis and psoriasis. And then you get IL-17 and 23 inhibitors, and I have great difficulty in pronouncing these biologicals, but it's secukinumab and ustekinumab. Many of these are tongue twisters. So we call them by the short name secu and SQ, like upadisumab. It's very difficult to say, so we call it UPA. And that's what we generally call them in practice. And this works against IL-17 and IL-23. So how do biologicals work? How do they specifically target the immune system? As you can see, I've shown you how a normal immune system works, and you can see how the biologicals specifically target specific aspects of the immune system. They either work on the cells, like B-cell depletion, they work on cytokines, like IL-6 and IL-5 and IL-13, in the case of dupilumab. We don't have time to go into all the details, but this is just to give you an overview of how biologicals work and how they target different arms of the immune system. And basically what they do then is by targeting the immune system, they have a downstream effect on the target organs, which is the bones or the lungs or the skin, wherever they are supposed to work. So this is how biologicals work. We don't have time to go into every single detail of how they work, but I can share my slide with you if you need them. So this is in summary how they work. For an example, abatacept works on, it prevents full T-cell stimulation. Your rituximab specifically targets your B-cell. It doesn't work on your T-cell, it works more lower down in the immune system. If you target the T-cell, you work high up on the immune system, it has a downstream effect. Your atezolizumab, your adalimumab, and infliximab, they block the action of tumor necrosis factor, which is very low down in the immune system. And your tocilizumab, which works on IL-6, specifically targets your IL-6. So let's go through each one very briefly, how each one works and what each one does. Your tumor necrosis alpha inhibitors, these are critical upstream mediators of joint inflammation. They act on endothelial cells, they act on activated fibroblasts and metalloproteases as well as your T cells. And these are some of the approved examples of TNF alpha inhibitors such as infliximab, atacicept, adalimumab, galuzumab, and certolizumab. So these are the different biologicals, and most of these are available in South Africa, and some biosimilars are available as well. So tumor necrosis factor inhibitors, such as the ones I've mentioned, they can target multiple autoimmune diseases, such as rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, juvenile idiopathic arthritis, and many types of non-radiological axial spondyloarthritis. It also has an effect on gastrointestinal disorders, such as Crohn's disease, ulcerative colitis, and inflammatory bowel disease. It also works against dermatological conditions, and they have indications for plaque psoriasis, for hidradenitis suppurativa, and we're involved in one of the trials at the moment with a new biological for patients with HS, and it's a very distressing condition where they get recurrent infections and pustular lesions, especially on the sweating parts of their body, under the arms and in the groins and so on. And so far, the biologicals that are available do not work very well. So we're involved in trials with some of the dermatologists for HS. And of course, the skin manifestation of Crohn's disease and many ophthalmological conditions such as uveitis as well. So these are some of the indications for tumor necrosis factor inhibitors. Let's talk a little bit about IL-6 inhibitors such as tocilizumab. They work for rheumatoid arthritis, juvenile idiopathic arthritis, giant cell arthritis, which is Takayasu's disease, Castleman's disease, adult onset Still disease, cytokine release syndrome, and of course it was used in severe COVID patients as well, and we often use IL-6 as a measure of the cytokine storm. Then the next class, the third class of biological drugs are B-cell depleters, and the one that we use commonly is rituximab. And rituximab is a chimeric monoclonal antibody. It's directed against the CD20 receptor on the B cell, and it's the most common cell surface molecule expressed by mature lymphocytes. So it works by B cell depletion, reduction of autoantibodies, inhibition of T cell activation, and cytokine production. So again, it has a downstream effect. The problem with B cell depletion is that you often get type of immunodeficiency, particularly your immunoglobulin immunodeficiencies such as IgM and IgG. And these patients have to be monitored very carefully. And as the previous speakers have mentioned, many of these patients have to be vaccinated for many of the adult diseases before they get the vaccinations. The side effects that we see with rituximab is angioedema, hypotension, chills, fever, and headaches. These are some of the indications of rituximab. You can see it's not for one disease only, it's for multiple indications, hematological indications, autoimmune diseases, neurological and other autoimmune conditions as well, for myasthenia gravis and for autoimmune encephalitis, which we sometimes see in children, including NMDA receptor encephalitis, which is a huge problem in children. These are children that have fits which are very difficult to control because they have autoantibodies against the dendritic cells. And rituximab is one of the drugs that we use in treating these patients. So there are multiple indications. Then the fourth category of biologicals is the co-stimulation blockers, abatacept. They're used for rheumatoid arthritis, for psoriatic arthritis, for juvenile chronic arthritis, and also for graft versus host reactions. Again, multiple indications for many of these drugs. And then your IL-17 and 23 inhibitors such as Secu and Bucel. They indicated for plaque psoriasis, for psoriatic arthritis, for ankylosing spondylitis, so mainly for many of the rheumatological conditions. So these are the various indications for the traditional biological drugs that we find. Recently, there's a new class of drugs. It's called JAK inhibitors. And there are two types of JAK inhibitors. Upadacitinib, we call it UPA, and baricitinib, which we use in patients with alopecia as well as vitiligo. So JAK inhibitors blocks the receptor on your B cell, which is a Janus kinase enzyme, and then this prevents translocation and prevents signaling, and thereby prevents the production of antibodies. There are many different types of JAK receptors, JAK 1, 2, and 3. You get JAK inhibitors that are pan-JAK receptors, work on all three receptors, and some are highly selective. So some of the indications, as you can see here, sarcoidosis, psoriasis, alopecia. We use JAK inhibitors in patients with atopic dermatitis, in Crohn's disease, as well as rheumatoid arthritis. So they have multiple indications. JAK inhibitors are not strictly biologicals because they are made synthetically. And they are small molecules, but they're not biologicals in the sense that they're made from living organisms. So these are called JAK inhibitors. Now, an area that's really my specialty is biologicals for asthma, chronic spontaneous urticaria, and atopic dermatitis, and I've been fortunate to be involved in numerous clinical trials with these drugs. And you can see they work at different levels. And many of these, what we regard as allergological conditions, actually have an autoimmune basis to them. As I mentioned, chronic spontaneous urticaria, and there's an autoimmune basis for atopic dermatitis as well. And you can see how different arms of the immune system are affected by the different biologicals that are used for asthma, chronic spontaneous urticaria, and atopic dermatitis. The one that we use commonly in patients with atopic dermatitis, as I mentioned, the JAK inhibitors, which is Runvo, as well as dupilumab, which is indicated both for asthma as well as atopic dermatitis. So dupilumab is one of the few biologicals that are available for asthma and atopic dermatitis. And there's also tezolizumab, which acts on your thymostromyl lipoprotein, also indicated for patients with severe asthma when your conventional treatment fails. So these are biologicals for asthma, chronic spontaneous urticaria, and atopic dermatitis. Now, obviously, if you are having an influence on the immune system, there will be some side effects to these drugs. But generally, they are much safer compared to the traditional immunosuppressants such as steroids, azathioprine, methotrexate, and cyclosporin. There's obviously an increased risk of infection, and certainly in a country like ours where TB is endemic, it's something that we need to screen for before we put patients onto biologicals. So the protocol that we follow is these patients need a full workup, particularly for TB. We do serum quantiferon levels, where indicated we do MANTUs and even chest x-rays to make sure that patients don't have latent TB before we put them onto biologicals. Then a very rare side effect that we see is infusion and injection site infection. So most of the biologicals are either subcutaneous injections or intravenous, whereas the JAK inhibitors are generally oral medication, and that's the difference between the two. There is some concern about malignancy, and in one of the trials that we've been involved with recently, there was an increased prevalence of Kaposi sarcoma in some of the patients that were using these biologicals. So there is a concern about that, and some of the biologicals actually come with a black box warning. So one needs to be aware of that. There is a small but not significant yet risk of patients developing malignancy while they're on biologicals. So many of these patients require routine and baseline laboratory monitoring. So we do baseline tests, we put them onto biologicals, and then we do routine lab testing for quantiferon as well as infection screening throughout the course of the treatment. So safety issues are important. Most of them are given parenterally, and these patients need to be strictly followed up and periodic assessment, particularly for reactivation of infection. And we need to make sure that many of these patients have been fully vaccinated before we start them on biological treatment. So for screening, we test for hepatitis, for TB. We make sure that they've completed all the vaccinations before therapy. We do periodic full blood FBCs, liver function tests, CRP, and ESR tracking. And of course, when you when you make the decision to use a biological, it's shared decision making, and often it's done in a multidisciplinary approach. Biosimilars are legally approved subsequent versions of innovators. So basically they're generics of your biologicals. They come up cheaper. Unfortunately, we don't have many biosimilars. They basically function like the original biopharmaceutical products, but in an affordable price. The global market for biosimilars is 2 to 2.5 billion rand in 2015, and it's much higher now. So in summary, biologicals for autoimmune diseases are a major advance in the therapy for these conditions. They are basically disease-modifying drugs, unlike the traditional and conventional treatments that we had for autoimmune diseases. They're not just treating the symptoms, but they get to the immunological basis of the disease. They are relatively safe compared to the general population, but the problem with all these biologicals is they are inaccessible to the majority of our population. There are huge costs involved. Just to give you an example, the biological that we use for atopic dermatitis in adult patients, dupilumab, which blocks the IL-4 and 13, the cost is 25,000 rand a month. And that's, the funders are not prepared to pay for it. The cost of Runvok, which is UPA, which is a JAK inhibitor, is about 9,000 rands a month for patients who have either Crohn's disease, rheumatoid arthritis, or ulcerative colitis, or atopic dermatitis. So there are huge costs involved. In a country like ours, where there is tremendous inequality in accessing health, most of these fancy drugs are not available to our patients. And therefore, as doctors, we need to be advocates for our patients. We need to put pressure on drug companies to lower the prices of their medicines. We need to put pressure on the funders to fund many of these biological treatments, which are a huge advance in treating autoimmune diseases. So we need to become advocates for access, so that our patients with many of these life-threatening conditions, which have an autoimmune basis, can benefit from drugs that are available to treat the underlying condition. Thank you for your time.
Jazakallah. That was a very good overview, starting with Immunology 101 and then progressing to the biologics, which are not expensive from what we're hearing. They're extremely expensive. They are administered parenterally, monthly, and they have side effects, but they are focused in terms of addressing the different autoimmune conditions. So very useful, but they have constraints in terms of access and availability, etc. Okay, the floor is open. Muhammad is standing. Okay, there's a question from Dr. Farooq, Umar Farooq Juma.
Assalamu alaikum. Ahmed, that was an excellent overview on allergies, immunology and the use of biologics, which is something quite, is progressing at quite a rapid rate. You may not have an answer for what I'm going to ask you. What's the duration of treatment I'm sure it will vary with different conditions. For example, in a patient with severe eczema,